Oh, look, some people are on video. How good are they that they know how to do that?
Just let me know when you're ready. You're good?
Okay.
I'm going to unmute us. Do a quick little intro. Hello, everybody in our virtual audience and on Win TV. Thank you so much for participating in this part 3 of a 3-part discussion on successful aging. Today, we are in partnership with the Windsor Commission on Aging, and I'm just going to ask that those in our virtual audience stay on mute during this presentation, and any questions can be asked in our virtual chat in the Zoom application. Without further ado, I'd like to introduce Sharon Gauthier. She is a certified dementia practitioner.
Yeah.
As well as gerontologist, and she is going to guide us through this session. Thank you so much.
Hi, everybody. Good to meet you all. So, as she indicated, I'm a registered nurse, and I have my own nursing practice that called Patient Advocate for You, which is really based around helping those elderly patients navigate the healthcare system. So for many of you that may have been in the hospital, you know how difficult that is to, especially now with masks, to navigate that system. And I help with coordinating all their care for them, along with bringing them home with care. We also have caregivers. Part of what I do as a certified dementia practitioner is assessments based on memory. So many of you may already had it's called the MMIR, I think it is, where your physician will ask you a number of questions and then come back to them and score it. That is a minimal type of testing that might indicate to you, not that you have dementia, not that you have Alzheimer's, but you might have some short-term memory issues. Alzheimer's, dementia, and memory issues aren't necessarily part of aging. To be totally lost in your car without having to be able to find yourself back home is not the normal part of aging and memory. So all of us as we get older, and I'm certainly one of them as I'm getting older, you certainly have times that you can't find a certain word, but then it comes to you later. Or you might not remember where you put something, but then you remember later where you got it. That is typical and normal as you get older to have those short-term memory issues that really aren't big issues because they're not impacting your activities of daily living. When it becomes a problem is when it impacts your activities of daily living. Activities of daily living are the things that you do every day on a normal basis as a routine. So you get up and you get dressed every morning, you might take a shower, you make your breakfast, you eat your breakfast, you take your medications, and then you go on with your day. When you have significant memory issues, all of those activities get impacted. You might forget to eat. You might forget to take a shower. You might be afraid to take a shower. You might forget to dress, or you might dress, but you're dressing for the wrong season. So one of the things I used to train my staff when I ran a federally funded clinic for a couple of years is that when an elderly patient comes into the practice and it's the middle of winter and they're wearing summer clothes, that's a red flag that something's going on with that person. And you really need to sit down and talk to them about what's going on in their life, because they obviously have some issues about managing their activities of daily living. And you would expect that someone in the middle of winter would have a winter coat and a winter hat and would have boots on. If someone showed up in our clinic and they had slippers on and they had a summer dress on and they didn't have a coat and they didn't have a hat, that was a red flag that we needed to go a little bit deeper. So when is it that you need to worry? Because I think we're all worried about that, and our families are worried about memory issues. I think you sometimes need to worry when your family starts to worry. when your family recognizes that there are things that are just a little off for you, it's very upsetting for you as the person to hear that, but I think it's important for families to be able to pick up on some of those cues in knowing whether or not you're able to function pretty well, like looking in your refrigerator. Is there a lot of rotten food in there that you've not thrown out? Are you losing weight? Are you not taking your medications? That they look at your medications and they see the last time it was filled, 6 months ago, and you haven't filled it since. I try to train families to be cognizant of all that when they visit their loved ones, because again, those are all red flags that something bigger is going to happen, where they may become very paranoid, they may start to hear voices, they may start to see people that aren't there, which can be indicative of a dementia, whether it is an Alzheimer's dementia or another form of dementia. There's a Lewy body dementia, or it also can signify someone with Parkinson's. Someone with Parkinson's disease can also display some of these same memory issues, some of these same issues with either hearing voices or seeing people that aren't there without having tremors. I've had at least a half a dozen clients in my career that had Parkinson's and did not have active tremors. So that doesn't always go along with it. So my advice to people as they get older is to listen to the people around you and also be cognizant of your routine. So routines are really important. 99% of the time, I normally get involved with a family in a crisis. And this is what I hear on the other end. I called my mom every single day and she seemed fine. Now she's in the hospital because she fell, and the staff is telling me that she needs to go home with care because they're worried about her memory. And they don't understand what happened. So this is what's happened. Mom has had a routine every single day that was never interrupted. And I can tell you, when you call your elderly parents and they ask you how you're doing, every single one of them is going to say, I'm fine. And you're not going to be able to pick up on any issues. When that routine is broken with something like a fall or a urinary tract infection, which is like the #1 clinical issue that people show up in the ER with, and that routine is broken, that's when those memory issues are going to show up the most. So she may have been home with this routine and did fine. Now everything has been disruptive and she's now in a new environment, and now it's showing up that she forgets who she is, she forgets what year it is, she forgets where she is. That's expected for someone who has some memory issues or a dementia of some form. When they return home and back to a routine, there's always an improvement. But that always existed with that person long before they went into the hospital. They just had a very set routine that had not been disrupted. And you can usually pick up on those kind of clients that have a little bit of a memory issue. So we have a client right now who fractured her hip. She's in rehab. She's very concerned about her husband being home alone. He's 81 years old. He's a non-insulin diabetic and uses a cane. He has oxygen at night, and she just wondered how he was doing at home. So we went to go visit him, myself and another nurse. The daughter comes to visit every week, cleans the house for him, makes his meals for the week. But this is what I noticed in talking to him. When we sat at the table, he had everything on the table in a very orderly fashion. He had his medications, he had his phone, he had the pen and paper. He had this whole system lined up for him of exactly how he's going to do things. So that's a gentleman who does have some memory issues. He appeared to be pretty cognizant of his own, for lack of a better word, his own memory issues. And because there was a sister-in-law stopping in several times a week, we were okay with him being by himself. But that's a man who definitely has some significant memory issues and probably should get further examined other than that mini mental exam that the doctor may do for you. Now, there are several places that you can go to and get a cognitive exam done. That's a little bit more thorough. The one that we do is not just cognitive, but we actually go into the home and we develop a plan that's a safe plan for that person, which may mean that they might need more help in the house. It may mean that they need Lifeline. You know, I will ask someone who has Lifeline, well, what would you do if there was an emergency? And I've had people say to me, well, I would just call 911 on the phone. Okay, well, if you were lying on the floor because you fell, what would you do? Oh, I don't know. I suppose I would crawl to the phone. These were people that were sitting there with their Lifeline pendant around their neck. They just did not remember that they had that to pull. Now, that being said, even if they remember that that's what they pull in case there's an emergency, I can tell you when an emergency happens and that kind of chaos comes into the life of someone with memory issues, their memory is going to be worse. Their cognition is going to be worse because they don't have the capacity to be able to deal with that chaos. So my advice to all of you is be aware of your surroundings, be aware of what your needs are, and understand that getting help preserves your independence. And I have this conversation more than once with more than one elderly person, you know, who doesn't want help, who wants to continue driving, who doesn't want anybody in their home. And what they don't understand is that they're an accident waiting to happen. And if you wait till that accident happens before you get the help that you think you might need, then it may be too late at that point, where you fractured something or something worse. The other has to do with driving. So I spent a good deal of my career in the ER, and I have been involved in more discussions than I would like to say with an elderly driver who came in who was not hurt, who was in a major car accident that either maimed or killed another passenger in another car. And I walked in with the physician in the waiting room to have the physician talk to the family about their loved one, only to hear family members talk to each other about how they felt that that person shouldn't be driving. And that should never happen in my mind. It just shouldn't happen. If someone is concerned about your driving, then you need to listen to that, because the last thing any of you want to do is get into a major car accident and hurt someone else. And it happens all the time. And I understand that driving is the hallmark of independence, but at the same time, there are a lot of different parts of your body you need to use in order to drive. It pains me when I go to Geysers and I see someone come out who can barely walk with a walker and gets into a car to drive. That concerns me as to how that person can actually drive. There is a place where you can be tested for your driving ability. In this state, you can get your license renewed until you're like 300 years old. In other states, like in Florida, where my mom lived for a while, when you were 80, they retested you, and she flunked her test. And the reason she flunked it was because she couldn't hear. She was deaf as a post. Her husband, who was my stepdad, couldn't see. So between them, they did not make one whole person in a car. And she consistently resisted not driving. And I would constantly get calls from the police who've stopped her because she didn't have a license and she didn't understand that she couldn't drive. I finally had to go down there and just take the car away from her so that she didn't drive anymore. But that's a safety net that that state has for the elderly. Connecticut doesn't have that. You can keep your driver's license for as long as you want and just get it renewed. You can request to be tested by DMV. They'll test your hearing, they'll test your eyesight. I'm not sure if they bring you on a road test, but they'll test your hearing and they'll test your eyesight. McLean and Simsbury has an entire program that you can pay for. It's about $325, where physical therapy, occupational therapy work with that person to see whether or not they're capable of driving. If they feel that they're not, then that information goes to the physician, and it also goes to DMV, and that person should not drive. So if someone is concerned about your driving, again, you need to listen to that and not be that stubborn 85-year-old who thinks that they can do everything on their own and end up in a big crisis, because, like I told you, 99% of my practice is around crisis. And it's because families either tried to get that person to understand that they had issues and needed help, or the person is by themselves and they have no children and family around. They didn't have access to getting help. Yes, you have to privately pay for it, but if you don't have the funds, there are multiple state programs now that you can qualify for based on income. And no, your children do not need your money. And that's the other thing I hear. I want to leave my children your money. We're not leaving our children anything. We are spending everything before we die. You know, your kids do not want your money, and they should not want your money. So if you have funds to be able to pay for the help, you need to get the help before it becomes a crisis. If you have a long-term care policy, awesome, good for you. You need to initiate that policy again before there's a crisis. Because if you wait till there's a crisis and you need to have somebody 24/7 as a live-in, you now have to pay that person for 90 or 100 days, because there are elimination periods on all of the policies before they'll start picking up on it. And why would you want to do that? Why not pull them in when you need minimal help, you know, 2 or 3 times a week, and then you go through your 90 or 100 days, you never have to go through that elimination period again, and now you have your policy that's paying for the care that you need, which is the whole reason you got the policy to begin with. Don't let it sit there, because there's nothing that you can cash in at the end of the day. So that's my spiel on memory issues. You know, be alert and aware of what your abilities are, be cognizant of what other people tell you, and be proactive in order to get help before you need the help. Now let's talk about insurance. The other call that I get often is, does Medicare pay for care at home? They do not. So how I explain it to families is this: Medicare is not proactive. Our entire health system is not proactive. Medicare is reactive to a crisis. So for whatever reason, Medicare wants to wait until you fall, fracture a hip, go to the hospital, go to rehab, and then come home, pay thousands and thousands of dollars for all of that, and rather than pay for you to have an aide at home. But that's the way our system is right now. So you can't depend on your insurances to pay for the care that you need at home. They don't pay for the care that you need at home at all. That's something that you're going to need to think about, unless you have family around you that are willing to do the shopping, that are willing to take you to the doctor's appointments, are willing to help you at home. If you have that, that's awesome. If you don't, you need to be aware of what your needs are. And I'm just going to open it up to some questions, because I find that that's the best way to kind of get to what it is that you might be interested in.
I have a question.
Yes. Oh, welcome.
Thank you. I'm sorry I came a little late, but there was a lot of traffic.
Yeah, there is construction everywhere.
Oh, but anyway, I know this question is kind of, doesn't mean too much, or we don't really have an answer. But what is about the age you find dementia starts setting in? About?
You know what, that's really hard to answer, because I've had people with early onset dementia in their 50s with early onset. There are some people who are predisposed to having dementia, people who've had a stroke, people who have had a head injury. We know that those 2 factors increases their ability to have dementia. People with psychiatric issues. I just left a gentleman.
I don't have good hearing.
people with psychiatric issues.
Yeah.
So I have a gentleman that I just left who's home with an aide who is a paranoid schizophrenic. He's been on psychiatric meds for years. He's also at risk for dementia. But then there are different kinds of dementia. You know, there's Lewy body dementia, which is more of a frontal lobe dementia. So your frontal lobe is where all of your emotions are. So those are the hardest type of dementia people to manage because there are a lot of behavior characteristics that go with it. They tend to be, you know, loud, they have no filters, they might swear. If they have an African American caregiver, they may call them names. You know, they have no filter at all, and they're very difficult to manage. They can manage them with medication, which is helpful, but they're difficult to manage. Global dementia, which might be your Alzheimer's, that all those plaques kind of sit in your brain that you don't really see until you're gone, is a little bit different. That's more forgetting. And eventually, their body forgets to do everything. You know, eat, urinate. Their body functions become impacted by it. That can be very lengthy. And normally, by the time someone has been diagnosed with dementia, they have probably already had it for 4 to 6 years before it's already recognized as being an issue. There are a couple of medications that some physicians will give them. Aricept is one of them. Namenda is another. I don't have a lot of faith in either one of those that they improve anything. I think that routine is what they need more than anything. So it's really important that people do have a routine. And also it's important, again, to listen to your family. Like my mother was convinced there was nothing wrong with her. The reason why she didn't get her license renewed was because she came from Canada, even though she's been a citizen for years. I mean, she had all kinds of excuses. She wasn't going to listen to me. I'm sure she had a form of dementia, but she passed away before we were able to dig deep into that. So again, I think it's just realizing that, and it's a lot more than just forgetting a name, forgetting a date. We all do that, and then we kind of come back to it. But just taking care of yourself, eating well, seeing your physician on a regular basis. The friendships you have around you are very important to keep those intact, because those are the people who are going to be honest with you and say, geez, I'm really worried, for whatever reason. And just listen to them and just get some help. People with dementia can stay home for a very long time with help. They really can. And the memory care units tend to be for people who have behavior issues and who might be at risk for leaving. And because you can't lock somebody in a house. So those tend to be the places that they go to, the memory care units. But there's no cure. There's nothing more than the ability to come up with a daily activities that are more routine for you so that you don't get frustrated. Because it's frustrating when you forget. If it's not frustrating when you forget a lot, that's even a bigger red flag. Like I did an assessment on a woman last week who's 81 years old. She has one son sitting on the couch next to her. And as I'm talking to her, I said to her, do you know who that is? And she goes, no, not really. She goes, he looks familiar. Didn't even bother her that she didn't know her son's name. That's somebody with pretty advanced dementia, that she's not even on the scope of, God, I wish, I know that person. I just can't think of the name. It's on the tip of my tongue. So it runs the gambit with everybody, just depending upon their personality. You're welcome. And if you're living by yourself and you have limited access to other people, that is difficult for you, right? Because you may not have family around you. Most of the people that we deal with, the families live out of state or out of town. Like I said, they might call every day and mom or dad says, I'm fine. They might visit once a year, but a lot of them haven't been able to visit for a year. So who knows what they're going to find when they visit mom and dad now, So I always say to people, please be proactive. and not wait till a crisis happens, because that's never a good time to jump in. It's not a good time for families, not a good time for me, because then I spend a lot of my time that they're paying me for to just calm everybody down. Okay, well, let's get to the nitty gritty of what we need to do here, and let's find a safe haven for this person. Any other questions out there?
Sharon, can
Yeah.
you talk a little bit about sundowning?
Oh, sundowning. So sundowning is very interesting. So there's a term called sundowning, which you can Google, and it really talks about when the sun goes down, elderly people tend to get more confused. Nobody knows why. I've had some clients that we were only in there at night because they totally did not know who they were, where they were, or what they were doing in the middle of the night. And that's also a common piece of a form of dementia that eventually may impact them during the day. There's also an ICU psychosis that is very common in the hospitals, and I worked in ICUs for a long time. And now they're saying that there's a COVID psychosis to those that are admitted. Not sure it's that related to COVID more than the fact that they were admitted in the ICU. But again, in the ICU, lots of noise, no clock, no calendar, different faces. You're there for a long time. It's very common that these people do become a little psychotic, but that is something that they will come out of once they're out of the ICU and they start maintaining a more normal life. But sundowning is a real thing. You can all look it up on the internet, and it does happen with older people where when the sun goes down, they get totally confused. And I've had conversations with families who say, oh, I call my mom every day. I'm like, call her at 8 o'clock at night and see how she is. And ask the right questions, because it might make a big difference on what you're seeing, that, that confusion isn't coming up until then.
Do you think it's because they're afraid at night?
I don't know whether it's fear. There's really no rhyme or reason for it.
Or it's darker or it's night?
No, because it also comes with people who are living as a couple, where one will go through it and the other one doesn't. So, no. Sometimes it might be related to urinary tract infection, which is the number one thing that people come into the ER with that are elderly. And urinary tract infections happen for a lot of reasons when you get older. One, and I just had this conversation with my 91-year-old this morning that I had to bring to the doctors. So she's on a diuretic. So some of the problem is that you don't want to drink, because if you drink, you have to go to the bathroom, right? And some of the problem is that as your bladder gets older, it doesn't have the ability to empty itself completely. So the less fluid you drink, the more residual there is in your bladder, and the more at risk you're going to be for urinary tract infection. Some people have chronic urinary tract infections because for a long time we were treating them regardless, which is why MRSA came about, and we ended up with people having difficulty with antibiotics. Right now, the geriatric physicians are very cautious about putting people on antibiotics for urinary tract infection. They'll take the urine, they'll usually send it for a culture. The culture will identify that bacteria, how much is in there, what kind of bacteria is in there, and they will decide whether or not they need to be on an antibiotic. So drink your fluids and go to the bathroom. That's all I can tell you. That would be the best thing, especially with the warm weather coming, to do that to keep yourself from getting a urinary tract infection, because the difference between you getting a urinary tract infection and her getting a urinary tract infection is completely different. You're going to become confused. You're going to become disoriented. You may not have a temperature. You may not have the ability to say you have a hard time peeing. She, on the other hand, will know she's got to go to the bathroom a lot. It's painful for her to pee. She can call her doctor and get it addressed. There's the difference between the age groups. So working in the ER, when we would get someone that would come in that's elderly and the family would say, oh my God, all of a sudden my mother is like confused as can be. We just don't understand why. The number one thing we would do is send a urine. And I would probably say 100% of the time they had a urinary tract infection. So then you do the education for people. It's all about education. It's the fact that any of you would even be on this to find out more about what you can do. It's a matter of just reaching out. And some people have their own concerns. My husband had concerns about his memory. And I'm like, all right, well, let me give you a memory test, which I did. And then he went to his doctor, and he was fine. He's 75. He's just a little forgetful, and that's okay. But he recognized that, geez, I'm really forgetting a lot. Well, you know, he's retired. He's got the grandkids. He picks them up. He brings them to school. He's kind of busy all day long. That also plays into it. The more chaotic your life becomes, the more difficult it is. I think we all recognize that as we get older, to manage that chaos.
I have a question about some of the questions a family member could ask to better gauge where the family member is at with onset dementia.
So that's really difficult on the telephone because elderly people are very sly. Like, they will find a way for you not to pick up on an issue. So what I would say is that they need to have somebody go in and check in on them occasionally, even if it's once a month, to just see how things look in the household. But I think asking questions that aren't yes or no questions, you know, like, what did you do today? Like, how was your day today? You know, if they went to the doctors and they just say, oh, the doctor says everything is fine. Well, what happened when you were at the doctor's? Did you go for blood work? Did he give you a new prescription? Did he talk with you? We all know you only spend 3 minutes with your doctor in the doctor's office, but, you know, rather than bringing them to yes or no questions, really get into what it is that they've done. What did they have to eat today? You know, and have them tell you what they had to eat. And ask them when they eat. When did they go grocery shopping? Who buys the groceries for them? You know, how are you paying your bills? Do you think you have any bills that might... Just start asking some of those questions. We ended up taking over my mother's bills, or my brother did, because he was the favorite, so she trusted him with her money. But we took over her bills for her, because even in Florida, I would go down every 3 or 4 months and check in on her. And I started seeing, and this is what families can do, I started seeing late notices for her electricity, late notices for other bills. I just gathered them all up along with her bank account info, and then we were able to monitor her stuff at night. It's a very fine line between wanting to take over and wanting to help, because you don't want to take anybody's dignity away. You don't want to take anybody's independence away. You want to preserve that in whatever way you want, but it has to be done in a way that allows them to do what they can do, and then the family or others can pick up what they can't. Any other questions? Yes?
I think you said at one point, if you come across a stressful situation, that makes the dementia worse. Is that what you said?
Correct. It does. It does. So someone could have dementia, a mild dementia, be home with a routine. Like that gentleman I went to go see, whose daughter visits every week, makes all his meals, his wife's in rehab. You know, when I went to see him, he had everything lined up and everything was fine. If that guy falls in the middle of the night, ends up not remembering his pendants on, ends up being found, goes to the ER, he's going to be totally confused, because he has a little bit of dementia, enough that I'm aware of, I don't know what level, but enough that I'm aware of, that if a chaotic situation hit him, it's going to throw him completely off kilter. Now, that being said, he could be in the hospital for 3 or 4 days, be totally confused, bring him back to his own environment, get him back on a routine, and he will improve. And you can't always think that it's gone when that happens. It really goes back to having that routine. It's so important to have a routine of some sort and just know where everything is and everything you're going to do.
But the dementia patient makes his own routine or her own routine?
Well, they either make it or we make it for them. So the ones that we're providing care for, because most of my staff have been trained with dementia patients, we develop that routine for them. So they know every morning at 10 o'clock they're going to have breakfast. We know, and we have a lady in Burlington right now who has dementia. She lives at home with an aide, and she has a very good routine. Every morning she gets up at 10 o'clock, she has her fruit, and she has whatever, then she has a snack, and we write that all down for the aide, so there's a routine. So she is absolutely fine in her little world. You know, you can't have a big conversation with her. She smiles at you, she answers questions appropriately, little hard of hearing. She'll recognize pictures when you show it to her. She's 90, she's going to be 91 in October, and she has dementia, but we've developed a really good routine for her. She's a little unsteady on her feet, and that's another thing. So peripheral vision for people with dementia is impacted big time. A lot of times the fall is the big indicator that there's some dementia on board, because they may not have fallen off of anything. They may have just fallen because their peripheral vision is off. That goes along with it, because remember, this is all in your brain, and your brain monitors everything. So if you have high blood pressure, it's going to impact you. If you've had a head injury, it's going to impact you. Not to say you're going to get dementia, but all of those dings to your system is going to impact how your brain functions as you get older.
When you say peripheral vision, I don't know exactly what that means.
So that means that their ability when they go up a step is to see the whole thing from here to here, right? That is impacted somewhat. So they're ones who tend to have an unsteady gait, tend to go to take a step when there really isn't a step there because their vision isn't that great. And also when they do take a step, they're almost afraid of it. They're also afraid of showering, and I'm not quite sure what the connection is there, but we've had a lot of elderly people who absolutely refuse to take a shower, and they're just afraid of a shower.
I can understand that.
Yeah.
I would think, you know, like sometimes you're afraid of putting the hot water in the cold, and you're afraid, well, maybe you'll turn it by mistake too much. You know, you have to.
Yeah, that's a valid point.
You
That's
know,
a valid
you have
point.
to sometimes, depending on the water situation, how it works, you know, you have to put the hot and the cold together to
Yep.
make it just right.
Yep.
And if you, by mistake, turn
Mhm.
it a little harder, you might have all hot water coming up. I mean, that's maybe.
No, I absolutely agree with you, and you brought up something very valid. It's those minute little things in functioning every day that we don't ever really think about, right? But as we get older, we do start thinking about that a little bit more. So, you know, again, I hope they find a cure for it. It would be awesome to do that. But in the meantime, there is no cure. It's a matter of routine and support, and that's what we provide. We help with getting a routine developed and a support system for them. That's it. All right. Listen, yes.
I'm sorry, I had a question.
Oh, God, the videographer has questions.
How many, or what's like the level of like dementia that a patient would have to know that they have dementia? Or does that make any sense? Like,
So most people don't know that they have dementia, no. And most people are very resistant to the fact that they have dementia. Some people will recognize that they have some memory issues, because really a dementia is memory issues. It has to do with memory. And they're not aware of it. But people around them will be aware of it. Sometimes they're remotely aware of it, like my husband. He's like, oh, you know, I forgot my phone here, and those are just normal things that probably even you at your age might do, because you just get really busy doing stuff. So they're not going to be aware of it. It's really, you know, to continue those friendships around you, to be able to have a routine. You might recognize it yourself. If you're over the age of 70, your physician should be doing those mini mental exams on you on a regular basis. It's not the end all to be all to say that you have dementia, but it's enough of a clue answering all these questions that you might want to dig a little bit deeper. And listen, those memory issues sometimes may have to do with a medical issue. Might not have anything to do with dementia whatsoever. So that's why seeing a physician on a regular basis to know you is important, because they'll start digging, not necessarily send you off to psychiatrists, but maybe they'll do a urine on you to see if you have a urinary tract infection. Maybe they'll look at your medications to see what you're on. There's a boatload of reasons why our memory might be impacted that has nothing to do with dementia. but it's seeing those regular people that know you to be able to pick up on those concerns and then start investigating it, you know. And it doesn't mean, again, that you have dementia or Alzheimer's. It just means you have a memory issue, and it could be a whole lot of reasons for it. All right? You're good. Take care of your mom.
Yeah, I'm asking for both parents, right? Yeah.
I know.
Yeah.
So listen, thank you very much, everybody. I am on the commission, and I'm very happy to be on the commission. I think what we do is very valuable. I think our senior population is very well supported in this town, unlike many other towns. I hope all of you have been vaccinated. I hope all of you are going to start seeing each other again. I hope we're all going to be able to hug each other again. And if at any time anybody needs any help, you can certainly call the senior center. They can connect you to me, and we'll be happy to come over at no charge to do a quick assessment and give you some ideas on how you can keep yourself safe. So everybody have a really good day today. It's beautiful out.
Thank you, Sharon. Thank you, audience.
Thank you.